Welcome everyone to our webinar, Cervical Cancer Prevention, Recent Progress and the Unfinished Agenda in Low and Middle Income Countries. I apologize from deep in my heart for the delay here. We're having trouble connecting with one of our presenters, but hopefully we've gotten that taken care of now. My name is Scott Whitted. I'm the lead for advocacy and communications for cervical cancer prevention at PATH, and I'm very honored to be on the virtual stage here today with three global experts on cervical cancer who I will introduce to you in just a moment. Before we get started with the program, a little bit of housekeeping. If you don't have your computer speakers on, you can't hear me right now, so I hope you're reading that first bullet. For everyone, we won't be using microphones this time. In order to submit questions, please use that chat window at the bottom left corner of your screen. And if you have a question for a specific presenter, please mention that at the beginning of the question. We'll be seeing all of those. We'll gather the questions, and at the end of the teleconference today, we'll have a Q&A session, and we'll get to as many of those questions as we can. This webinar will be archived online, both the slides and the audio. Once it's been posted, we'll share the URL through our HPV Flash e-newsletter. If you don't subscribe yet to HPV Flash, you can at that email address at the bottom of the screen. And don't worry, I'll show that email address later on as well. Wow, my presenters today, as I say, I'm very honored to be working with Dr. Gina Ogilvie, Dr. Sharon Kapambwe, and Dr. Ophira Ginsberg. I will be telling you more about each of them just ahead of each of their presentations. The information presented today largely comes from a new supplement to the International Journal of Gynecology and Obstetrics, and this is an open access issue. You can download any of the papers or all the papers for free from that URL at the bottom of your screen. I'll show this slide again at the end as well, so you have time to write down the URL. So cervical cancer, it's not a great mystery how to solve the problem of cervical cancer. We know what to do, and we know how to do it. We have tremendous tools. We have an effective and safe HPV vaccine and feasible, affordable pre-cancer screening and treatment modalities. And we know how to use them. We have great operational experience from all over the world and lessons learned from many countries. There are a lot of people who can help countries to plan cervical cancer prevention programs, some of them also the panelists on this call and many others. The other very exciting advance or situation is that our expanding partnerships. We especially have new stakeholders coming in who are interested in cervical cancer for lots of reasons, especially those who are very concerned about the health of HIV-positive women. Also, this past year, the United Nations convened a group of 7 UN agencies to come together to fight cervical cancer together, so we're very excited to see what they come up with in the future. Challenge continues to be political will and funding. We need governments to be making sure that ministries of health are including cervical cancer among the services that they provide, and we also need to know that governments, the legislatures, are allocating funding for cervical cancer prevention, and that international donors are helping countries to scale up the prevention to reach all the women and girls who need help. So what's the vision? Well, 25 years ago, people thought that there was very little we could do for cervical cancer prevention. Pap smearing wasn't feasible in most low-resource settings. But things have changed a lot in the last couple of decades. We now have many more options, and we can see an end to the suffering and the mortality caused by cervical cancer. We have a clear vision of cervical cancer elimination down the road. And Dr. Ginsberg will be talking much more about that later on. The burden of cervical cancer is heavy. Every 2 minutes, a woman dies from cervical cancer. That's over 260,000 deaths every year. HPV vaccination is fantastic and it holds great promise, but many women still require screening. In fact, there's a backlog of 700 million women in low and lower middle income countries who will need screening in the next decade. And this burden mainly falls on the poor. 85% of deaths are in low resource settings. Mortality rates in Africa, for example, are many times higher than in Australia, and cervical cancer is the leading cause of female cancer deaths in 38 countries, mainly in Africa. Again, there is good news. Prevention of cervical cancer is very cost-effective. In fact, one screening method, visual inspection with acetic acid, was called the best buy in global health by WHO, and they are highly recommending that countries take it up. Now, this cost-effectiveness is especially true for populations with high numbers of HIV-positive women. These women are at the greatest health risk, and there are platforms in place already to serve them, platforms which could integrate cervical cancer prevention. So thank you very much for your patience for starting up and for my short comments here. I'm very excited now to move on to our first presenter. Dr. Gina Ogilvie is a Tier 1 Canada Research Chair in Global Control of HPV-related diseases and prevention, and she is a professor at the University of British Columbia in the School of Population and Public Health. Dr. Ogilvie is also a senior public health specialist at the British Columbia Center for Disease Control, and she's a senior researcher at the British Columbia Women's Hospital and Health Center. Dr. Ogilvie, the floor is yours.
Oh, thank you very much, Scott, and it's great to be here. It was a real privilege to work with this team to prepare the supplement, so I would encourage everyone to take a look at it if they have a chance. So I'm going to review today just some of the fundamentals around the really foundational tools we have to actually prevent cervical cancer. So, oops, just went too far there. So the first exciting opportunity we have is that of primary prevention, and that's with the HPV vaccines. The vaccines are nearly 100% effective in preventing the infection that is targeted by HPV types and the resulting precancer as a result of those HPV types. Our current data for certainly the two vaccines that have been around for over a decade is that they offer long-lasting protection, and that protection is for both the acquisition of HPV infections, but also for those precancerous lesions. The profile has been excellent in terms of its safety. We now are well over 200 million doses having been given worldwide, and really the main safety concerns that we find are that of local reaction, so pain, redness, swelling at the site of inoculation. But beyond that, a very impressive safety profile. The World Health Organization originally made the HPV vaccine recommendation in 2009, but more recently, along with other leading health agencies, has recommended that 2 doses of the HPV vaccine, given at least 6 months apart, is as good as 3 doses. So that was an important change, and hopefully with positive impacts for global vaccine programs, as they would have to purchase fewer doses. In addition, there's an aspiration that with fewer doses, we would also be able to improve coverage because we would only have to get 2 doses into girls instead of 3. But despite that, only 1% of girls worldwide have been vaccinated. So we have a lot of work to do to get this tool that we know is effective into the arms of girls who we know would benefit from it. The impact of the vaccine, both from its immunologic endpoints, but also from its disease endpoints, certainly surpassed expectations. We see not only protection against the types contained in the vaccine, but we also see cross-protection, and depending on population levels of coverage, we also see herd immunity. So we see benefits both for other girls of the same age, we see it for boys in the same age, and even for cohorts older. And so that's been a real added benefit. So widespread coverage not only benefits the individual themselves, but also the population. One of the new updates is the recent 9-valent, which has been used in the U.S., jurisdictions in Canada. Many jurisdictions globally are starting to use it. And other places are also looking, as they go to move towards the 9-valent, looking at the cost effectiveness of the additional 5 types and the protection it offers. There have also been significant price reductions since 2006 for the bivalent and quadrivalent vaccines. Gavi pays about $4.50 per dose. The Pan American Health Organization revolving fund, they negotiate prices for different parts in the region. And there are also new manufacturers in the wing, and so that will perhaps increase the competition and thus have an impact on pricing. So we just talked a bit about primary prevention, moving on to secondary prevention. We know one of the reasons why we are actually able to address and prevent cervical cancer is that we have a pretty good idea of its natural history. So we know that persistent HPV infection can lead to precancer, which can then, of course, lead to invasive cancer. So by screening and trying to find these precancerous lesions, we can then prevent the progression of these precancerous lesions to cancer. Now, in high-income settings, high-income settings, we see that there are cervical cancer screening programs, and those have existed for a long time. But outside of these countries, often there's less structured programs and less established infrastructure to lead those screening programs. And without a real significant effect and a real significant attempt, to increase screening efforts, by 2030, we anticipate that cervical cancer deaths will actually rapidly increase to about 700,000 per year. As Scott alluded to earlier, there are new methods, even inexpensive ones like visual inspection with acetic acid, that have been proven effective in many countries. And VIA, although imperfect, is actually a very good starting point for countries without structured, widespread programs. But all the data would show that if we can move towards HPV DNA, that is the best approach that we should have. So our screening treatment and recommendations is there is a consensus globally that primary screening method, where possible, should be HPV DNA, where it's possible and where it's affordable. We recognize, though, that VIA is an important first step for certain jurisdictions, and it's also helpful to guide treatment decisions in women who are HPV positive. One of the really exciting opportunities that I'm interested in, and many of us are interested in, is the opportunity for self-sampling or self-collection, where women themselves don't need a clinician to gather the specimen for testing. And that can be done actually not just in clinics, but in homes or in places of community gathering. And so then what happens is we can determine which women need closer follow-up and need to attend to a clinic, and which women don't need closer follow-up and can be screened again in the next 5 to 10 to 15 years. It's also a very significant opportunity to increase participation and coverage of secondary prevention or screening. At the same point, it's really important with screening and secondary prevention. There's two parts to it. There's getting women, in this case, to have the screening test, but then it's really incumbent on a system to allow them to get treatment for those lesions. Screening isn't helpful if we don't have follow-through. So one of the other big areas we've been looking at is management of screen positives, so either VIA positive or HPV positive women. Those are evolving, and they're a really important step to sort of discern what is the best approach. This is often the weakest component of screening programs in particularly low and middle income settings. But ablative treatments are very promising. Cryotherapy, thermal coagulation, you may have heard of it, called cold coagulation. And what those do is they actually, once you see a precancerous lesion, they actually eradicate them very effectively. There's low side effects rate, very easy to use, and feasible at lower levels of the health system, so you don't need a large infrastructure. So so there's certainly new devices coming on board, and we need to evaluate those in the appropriate setting. So thank you very much. Again, I echo Scott's gratitude for your patience, and I'll hand it over to my next colleague who will be speaking.
And actually, I'll take care of introduction for, there we go. Dr. Sharon Kapambwe is the National Coordinator for Cancer Prevention at the Ministry of Health in Zambia. Sharon coordinates the cervical cancer prevention initiative in her country using the VIA screen and treat approach on a very large scale, and this has helped to initiate, sustain, and expand cervical cancer prevention services not only for HIV-infected women, but also for the general population. Dr. Kapambwe directed a 2-year HPV vaccination demonstration project in the largest province of the country, which saw over 50,000 girls vaccinated. Dr. Kapambwe has been seconded to the Ministry of Health from the Center for Infectious Diseases Research in Zambia, where she was director for cervical cancer screening programs for almost a decade. Dr. Kapambwe, please take the floor, and when you're ready to switch slides, just let me know, and I'll take care of that for you.
All right. Thank you so much, Scott. Thank you, everyone, for this wonderful time of presenting and exchanging knowledge. As has been mentioned, I'm seconded into the Ministry of Health in Zambia. Next slide, please. So if we go back and talk about the scaling up of HPV vaccination, as was mentioned by the last speaker, where
oh my gosh, we've lost Sharon. Christina, the operator, are you still on?
Yes, I will get her reconnected.
Okay, thanks. Sorry, folks. Great advantage of technology is we can reach all the way to Zambia, and downside is we can't always reach. Hold on just a moment while the operator connects Sharon again.
so when we talk, okay.
Sharon, you're back with us? We lost you
right,
after about the first. We lost you after about the first point of scaling up HPV vaccination.
All right. So when we look on a scaling up of HPV vaccination, as was mentioned by the last speaker, where we only see about 1% of the eligible girls being vaccinated, it shows that as a community that is looking into cervical cancer control, we have a lot of work to do, and knowing that the majority of the burden is coming from the lower to lower middle income countries. The good news is that at least we have more than 100 countries that are delivering the vaccine to some of the population, and in that 100 we have at least 43 countries which are low to lower middle income countries. When we look at the coverage of population-based programs, it's ranging. You find that in the USA they have approximately about 32%, and when you look at a country like Malaysia, where we have 98%. And then the other good news, though we could do better, is that we have about 20 countries into the low to lower middle income countries, which are planning or are poised to start scaling up in the next 4 years. Next slide. Next slide. So when we look at scaling up of screening and preventive treatment, 10 years ago, even in Zambia, when we look at 10 years ago, there was no low to lower middle income country that was doing any screening. Several countries were having limited programs, but now we've seen that those programs have gone up to a population level. We have Bangladesh, some countries in point, Bangladesh, Guatemala, Honduras, Nicaragua, and Zambia, which are using the WHO recommended screening modalities that respect budgetary constraints. And I think that is very important to be able to know that when you are trying to scale up a program to national level, you have to look at your budget and be able to know what is it that is going to work. You also need to look at the improvement of the access for women. How are we going to make sure that each woman who is in the eligible population has a possibility, has a potential to access that screening? And looking at the health systems that exist in most of these countries is also to how are we going to overcome the various bottlenecks that we have. So in the scaling up of the countries that have been mentioned is that they looked at these modalities and making sure that they were taken into consideration. So for a long time, there has been this, 80% coverage for you to see much reduction. But new evidence and modeling is beginning to show that incremental improvements can be obtained to reduce the disease. And we also have now the self-sampling, which has a lot of potential to reach more women, because if a woman can be able to bring in, or we can be able to collect at the community level when they have taken the specimen themselves, some of the cultural barriers that go with women coming into the clinic for screening are also taken care of. So self-sampling potentially is something that we need to look at because it does have a great hope. Next slide. So the other thing that we have to look at is data. And we know that from most of our countries, we really, from the low to lower middle income countries, one of the biggest challenges that we get is data, that we make decisions but we do not have sufficient, reliable data that we can use for strategic planning and advocacy or decision making. But we also know that maybe even from the records that could just be limited to facility-based, that we do have a huge burden. And it is not only the issue of cancer of the cervix, but this is a problem that we have with all cancers. So as we think about programming, it is important to look at the expansion and improving of the health information system as one of the priorities as we start looking at evidence-based information, evidence-based medicine, that we are making decisions which are based on evidence that is obtaining in our country. That said, there are some program managers, some programs in different regions that have started adding cervical cancer indicators to the government data system. So you find that they've added it to the HMIS. Especially we find some countries in the HMIS, they've gone to the DHIS2, and they're adding these indicators. The other thing that you see on the ground is when you find these indicators are in the government data system, it kind of also gives the nurses at the lower levels who are doing the screening, or whichever cadre of health workers that are doing the screening, to feel that this is actually part of the government agenda, that they're not fulfilling an agenda which is coming with a donor or a funder, but they see it in the government system. It does, to a certain extent, I see that it does work also to improve ownership. Next slide. And the other thing we've seen is the integration of cervical cancer with HIV and family planning and other reproductive health services that offer many potentials. We have African countries that have integrated cervical cancer with the existing family planning. We have Kenya, Nigeria, Tanzania, Uganda, and Zimbabwe. And we see with HIV, there are other countries that we can look at: Ethiopia, Kenya, Malawi, Tanzania, and Zimbabwe as well again. And I know that Zambia has equally used the HIV platform to a very large extent to deliver the services to the women who are HIV positive, even the women who are not yet HIV positive, who are not HIV positive. So this kind of integration can only be successful if it's reflected across all dimensions of the health system. We have to look at the policies. We have to look at the financing. You look at the governance structures, the staffing, the training, the monitoring and evaluation, the supply chain management. When you look at most of our procurement systems, they don't yet have how this supply chain management for cancer of the cervix in screening terms, in vaccination terms. So these are things that we're just beginning to add on. So integration should be looking at a whole big picture of the different parts of the health system. Next slide. The good news is we're beginning to see also a lot of new partnerships. And we find that cervical cancer prevention is quite a low-hanging fruit on the broader cancer agenda. Like it was said, we know the natural history, we know what can be done. There has been a lot of support for prevention at high level. Statements by the UN Secretary General, and Ban Ki-moon, the former UN Secretary General, the U.S. Vice President Joe Biden, the former Vice President. We find that we have it in the Sustainable Development Goals. Number 3, to reduce premature mortality from non-communicable diseases by 2020. And now we have the new UN Joint Global Program on Cervical Cancer Prevention and Control with the 7 agencies, which includes the WHO, we have UNFPA, we have UNAIDS, so some of the organizations that are working in the UN to ensure the agenda of cervical cancer prevention is going ahead. We have 11 active global or regional cervical cancer specific coalitions as well. Mainly are nationally focused partnerships. We've got new resources. Zambia is one of the countries that has benefited from the support of the Global Fund. The opening up of new clinics, we are opening 25 clinics by the end of the year from the Global Fund. And in the next cycle, for the next 3 years as well. Next slide. So I think as far as effective programming, that is what I can share. Thank you so much.
Thank you so much.
All right.
Thank you so much, Sharon, and for this for your interesting presentation and the good news about things that are available. My next presenter is Dr. Ophira Ginsberg. Dr. Ginsberg is a medical oncologist with expertise in cancer genetics, epidemiology, prevention, and screening, and she leads a research program in cancer disparities and global women's health. She was a medical officer at the World Health Organization from 2015 to 2016, where she provided technical assistance on national cancer planning and policies for breast and cervical cancer control. In March 2017, Dr. Ginsberg began a new post as director of the High-Risk Cancer Genetics Program at the Perlmutter Cancer Center, New York University Langone Health, and she is associate professor in the Department of Population Health at New York University School of Medicine. I would ask my other presenters to put themselves on mute while Dr. Ginsberg is presenting, and Ophira, please proceed. And take as much time as you need. We're good on time. Thanks.
Thanks very much, Scott. I'm delighted to present today. This is an issue that is so very important, and I'm very pleased and I have the honor of following the previous speakers who are so well-versed in this topic. So we've already heard that the call for the elimination of cervical cancer as a public health concern has been made. In fact, it was made by the UN Secretary General on World Cancer Day in 2016. And at that time, just to mention that the UN Joint Global Program for Cervical Cancer that has been referred to is now actively looking to other partners, including civil society, because we understand that no one organization, no one entity or even country can necessarily accomplish this alone. Zambia provides a superb model, and I commend Dr. Kampambwe on her efforts in that country. So the elimination of smallpox seemed like an impossible task, but since then we certainly have achieved this, and it showed the value of immunization, led to the creation of the expanded program for immunization, and really put forward a clear vision of what is possible when we work collectively with a common aim and we have the tools. You've heard this now several times on the webinar that we do have the tools for cervical cancer prevention and control, and we really have to move towards this aim together. There's a growing awareness that cervical cancer prevention is critical for women living with HIV. And UNAIDS is part of the UN joint program and has really led quite a lot of the efforts now to let people know, for countries to understand what the risks are for women with HIV, particularly if they're on antiretroviral treatment, which is a terrific accomplishment. There's still room to move, of course, but it's a tragedy if a woman is being managed well with her HIV and then dies a few years later of cervical cancer when it's entirely preventable. So starting with HIV-positive women, we really have to find better ways to reach women at risk, and then this can also serve as a model for leveraging synergies for reproductive health and primary care clinics, as I'll describe a bit later. In the series that you've heard about, the article by Campos et al. Calculated the cost of a basic program of vaccination, once-in-a-lifetime screening, and cancer treatment for 50 low and lower middle income countries over a 10-year period. Now this is important because we haven't yet heard today about what all this costs and how cervical cancer prevention and control can be framed and should be framed as an investment for the future of a country in terms of the health and well-being of girls and women. So in this paper, Campos and her colleagues noted that, or they actually calculated using modeling data, that only 3.2, I'm saying only for a reason, $3.2 billion US is required to vaccinate 160 million girls with 2 doses of vaccine and screen and treat 170 million women. The impact of this is that this $3.2 billion would avert 5.2 million cases of cervical cancer, that's invasive cervical cancer, can prevent 3.7 million deaths, and 22 million DALYs, that's disability-adjusted life years. Now, why are the DALYs so high? With cervical cancer, this is a disease that primarily affects women in the prime of life. The conclusion they made was that the investment in prevention could really prevent a substantial burden of disease while providing good value for public health dollars. The next, most important thing really to use this data for is to look within your own country, and if you're working in civil society or in academia, how this kind of information can be used in terms of public policy, getting the message out of why the cost of inaction is just too great. $3.2 billion over 10 years is really not very much when you think about 50 countries benefiting, 3.7 million deaths averted. In the same series of articles, there was a call to action with 7 key recommendations. This was a call to action made by senior representatives from a number of core agencies, of course, including PATH, Gavi, also the UNFPA, that's the Population Fund, as well as the World Bank and others. WHO was represented by the director of the African region, AFRO. The first was the focus on scale-up, and you've heard some of this by my previous speakers, the importance of moving now from pilot and what's sometimes called demonstration projects to scaling up both HPV vaccination and also screening and treatment throughout countries. And we would encourage you to consider models for this. Zambia is one model, Bangladesh is another excellent model where the challenges were great, but there have been tremendous progress made in scaling up to the women who need it. I would also suggest that you speak with the other partners that we've mentioned, civil society, and the UN agencies, which may be able to provide some technical support, guidance, and also direct towards funding opportunities. Seeking synergies and increasing integration is the second very important key recommendation from this call to action. Synergies were referred to by Dr. Kampambwe and also Dr. Ogilvie. This can include, of course, for the women living with HIV, offering cervical screening and treatment, as well as at least information for their daughters on HPV vaccination, if not actually providing it in that setting, as well as other reproductive health clinics and primary care. Integration, of course, costs less if you can provide even 1 or 2 days a week in a clinical setting where nurses are already trained to do various reproductive health services to provide VIA, it can serve as a very important sort of nidus for increasing availability. Creating seamless linkages also between screening and treatment, and I'll just put a bit of a word out there, because as you increase your population coverage of screening and treatment of precancers, you're going to also identify those women who have early stage invasive cervical cancer and also, of course, require treatment. This is a potentially very curable disease at that stage, but there have to be services in place. Now, we can't wait for every region and every setting to have all of the aspects of cancer control available before we start screening, but just to be aware, this should be a trigger, especially for ministries, to think how they can also leverage resources to provide at least good quality gynecologic surgery that's critical for women with early stage invasive disease. Radiation is the other piece to that. Happy to discuss that in Q&A. Increasing confidence in the interventions among policymakers and the public. This was key recommendation number 5, which really refers to the public perceptions and also, in many cases, the providers and even ministries, which need to work together to overcome some of the misconceptions and misunderstandings around vaccines. We are seeing this increase in many countries, including high-income countries, and we have our work to do to help the public and also other healthcare providers understand why we have strong recommendations from the World Health Organization about safety of HPV vaccination, and at the same time to address concerns on the cultural side where modesty is sometimes an issue. There can be stigma as well, and so appreciating and understanding that these are educational aspects that we need to overcome as well will help us scale cervical cancer prevention nationwide. The 6th recommendation is about capturing reliable data. We've heard a lot of this already today. I'll just reiterate what my previous speakers have said. Having indicators, I really like what Dr. Kapambwe just referred to. Indicators meaning that we have metrics, numbers we're expecting to see, let's say WHO is asking or a donor is asking, etc. But ultimately, the government can and should show leadership by asking health providers to provide data from their clinical services. And this can in turn show the healthcare providers that the government is really in this, that this is all a team effort for the country to move forward and to show where the improvements are being made and where there are gaps for improvement. Lastly, the recommended actions are to improve access to invasive cervical treatment, and that's something that we can address in the Q&A. I also like to think of cervical cancer in a way is the, let's say, Trojan horse. It's a cancer that we have so much data on in terms of our capacity to prevent and even eliminate this disease in a generation. And by highlighting this and focusing on this cancer, we don't intend to promote vertical programs, but rather to show what can be done as an example that can also help build cancer services capacity for the other cancers that are common in all countries. And with that, I'll end this part of this session.
Thank you so much, Ophira, for a really insightful and interesting presentation. So now it's time to move on to our Q&A section. We have a number of questions that have been sent in. It's not too late. If you'd like to submit a question, please use your chat window, and we will get to it if we possibly can. Sharon, I'm just going to check that you're still on the line and unmuted. The first question is going to be for you. There she is.
Okay, I'm here.
Good. So one of our participants asks that you mentioned that the Global Fund is supporting the opening of clinics in Zambia. are these cancer clinics or are they HIV clinics that will provide integrated cervical cancer screening? And that's the main question, but I'd also like you to talk a little bit more about your program in Zambia and especially any challenges that you've seen and how you've dealt with those challenges. Thank you.
All right. Thank you so much, Scott. So I think I need to start with what exactly happened to be able to get global funds. So what of course, with that there was a meeting of the board a committee from Global Fund to include the HIV comorbidities and cervical cancer when they discussed hepatitis. There was also cervical cancer that was brought on board, affecting the women who are living with HIV. So seeing that window, what had happened in Zambia is that we did have some gains that we had gotten, either because some programs had delayed and we were reaching the end, and of course having the country's instability in the currency made us have more money, and with that money there was a need to rebudget. So the cervical cancer team, the cancer team in the Ministry of Health, worked hard to lobby with the leadership at the ministry to be able to give us some of that money to be able to open new cervical cancer screening clinics. With a focus on looking at where we have highest infection, so we were looking at priority areas for Global Fund, for PEPFAR, that had been mapped, where we know that this is where we needed to scale up, this is where we needed this intervention. So after that lobbying and looking that there was this opportunity by Global Fund that we could actually use some of the money to be able to provide cervical cancer screening services for women. The first priority is women living with HIV. Now, the way our cervical cancer screening clinic operates in Zambia is, other than just doing the VIA screening and treating with thermocoagulation, is that we also include the nurses counseling for HIV testing. And our country now has moved to universal routine testing, meaning every woman who comes in for screening is offered HIV, which we started a long time. So yes, and with that, we were able to lobby, and once the leadership was lobbied, the country coordinating mechanism was informed, and then to Global Fund, and they looked at our request, and we were given resources to open up 25 clinics from the gains that had been made by Zambia. So what that allowed us to do, it was mostly setting up the clinics and also a bit of mentorship, hands-on mentorship that VIA is. What that has allowed us to do is that we now, when we came to application for the next 3 years, because this cycle ends this year, for 2018, 19, and 20, is that we were also still able in the HIV funding to lobby for more clinics to be open, looking at awareness, especially strengthening the linkages between the ART clinics and the cervical cancer screening clinic. Because one of the things that we're looking at is to ensure that every woman who is enrolled in the HIV program in those high priority clinics that we selected get screened for cervical cancer. So that has been how we've been able to get in Global Fund now. We are waiting for the approvals have been done, and I think the defense of the budget. And in the budget, going as we have planned as a nation, together with agreement from the country coordinating mechanism, is over the next 3 years, we should be able to open 66 more clinics. That means with Global Fund, we'll be able to open close to 190 clinics, or plus 90 clinics up to 2020. The Zambian program also launched the National Cancer Control Strategic Plan. So we also had a document to give the Global Fund, because they asked, can we see the roadmap? How are you envisioning this service? Is there anything written? So we were able to submit our National Cancer Control Strategic Plan for the next 5 years to the Global Fund, so that they saw that the things that we were requesting for were already in our strategic plan. What have been some of the challenges that we've faced as a country in terms of programming of the cervical cancer services. One, when you look at the see and treat VIA modality that we got, one challenge we were using cryotherapy as a country. The challenge we've had is that we have to import the nitrous oxide from South Africa. So we have a logistical problem. So we started having, again, women pending on cryo. It wasn't only about the turnaround time to get the gas, but it was also the cost of the gas once it was in the country, which started taking up the huge budget. So the country started leaning towards looking at other new ways of treatment, and thermocoagulation has been one of the things that we've used. What we have seen is that when the last 1 year I have spent at the ministry has been basically going around the country and seeing what is happening, is that you really need to have an intensive mentorship program to be able to drum up, increase awareness all the time, and to ensure that the data that is being collected is of quality and looking, because sometimes when you leave, we have a distance consultation, but sometimes internet becomes a challenge, so the nurses can't consult. So countries that are looking at scaling up should also look very critically at making sure that they have intense supportive supervision, even mentorship program for these VIA programs. And looking now that we've laid a foundation with VIA, the country is now looking at how we can put HPV testing. And we have gene experts. We're looking at a possibility of using the gene experts, and the country has over 100 gene experts, which are installed in different sectors. And you find that over 50% of those gene experts are where we already have existing screening programs. So you don't disturb what is already existing, but leveraging the existing gene experts. The problem is the high cost of the reagents that's going to come in. But we have the machines. Can we try now to be able to add HPV testing? It might not be that we go full-fledged for the whole nation, but what has to happen is that we start where we have gene experts, and it still becomes a single visit treatment, except see and treat, except that women will wait slightly a bit longer than they usually would. And I already talked about the aspects of M&E, even in terms of M&E. As long as things are not, when you have a national program and it's not feeding into the government system, to a certain extent, the government cannot make decisions. When you look at our HMIS, which we are now looking at restructuring and increasing the number of not only cervical cancer, but cancer indicators. We only had how many women have been screened for cervical cancer, how many women have been referred for cancer, and how many women have been treated. And that was it. So with such number of indicators, it becomes very difficult for you to convince government this is a problem, this is what we are seeing. Pathology is a huge bottleneck, which we keep confronting and looking at other modes of having telepathology. I think I will leave it at that for now, Scott.
Thank you, Sharon. That was really wonderful, and we're so fortunate to have someone with your personal experience of setting up a country program on the call. And while I know you are a very, very busy person, I hope that you'll be available to other countries to give your advice as they start up programs, because you have so much good experience. We have a bit of a technical question, and I'm not sure who on the panel might be most interested in responding to it. Let me read it out, and then if any of the three of you would like to take it on, let us know. It has to do with the sensitivity of VIA. The question is that according to Bayes, a researcher, Bayes calculation, the probability of CIN2 plus detection with VIA is 4% at sensitivity 36 and 10.8% at sensitivity of 70. The calculated probability of detecting CIN2 with VIA, is it, I think the questioner is asking, is it that low, such low sensitivity? Anyone like to take that question on?
It's Gina. I can start, and then folks can jump in. I think the real challenge for sensitivity for VIA is that while we have estimates of its sensitivity, it really is so operator dependent, and that's why we've talked a lot about the need for ongoing clinician mentoring, ongoing clinician continuing health professional education, because, for instance, in the big study in India, you had a range in sensitivity of VIA from 62% up to about 90%, depending on the site and depending on the operator. So I think that, to me, is the biggest challenge with VIA, and I think, as we've said, it is a very important first step. I think the experience with Zambia totally proves that. But I wouldn't actually I don't think there's a reliable single estimate for the sensitivity of VIA because of how user-dependent it is. And that's why I think we really encourage that as a starting place for jurisdictions where that's appropriate, but the continue evolution to HPV testing, which does have a much more reliable sensitivity. I don't know if the other two speakers want to comment.
I think you've basically said what I was thinking, and I can give just a scenario of how even within one country the sensitivity can differ, and because of it being a subjective test. So you find that if I'm looking at the nurses who are, one, very experienced, they've been doing this for a long time, they know how to separate the chaff from everything, you find that even just in terms when you look at suspecting cancer, for example, and when you compare with the histopathology, we did run locally trying to see when the nurses say suspected cancer, how much of it actually is cancer. When you look at the nurses who are very experienced and they've learned how to separate what is real, what is not real to a very large extent, they can be at almost 80%, 90% being accurate. But when you go down to the nurses who are working, miles away and they're not being supervised, you find that the way they look at things, all of a sudden it starts changing, especially if you're not going back and reinforcing the training and looking at them and looking at their work so critically. Even a nurse who was really good, when you leave them on their own, we have noticed with some of their nurses, you haven't checked on the work. It's 3 months. When you go back and you're like, but how did you treat this? This is just metaplasia or something like that. So looking at VIA, it's all about the subjectivity that we have. That's varying this sensitivity in different countries. Some will say, no, we have a sensitivity of 70%, 80%. And other countries, no, it was as low as 23%. And we also saw that it got lower for one of our studies in the HIV, in the women who were living with HIV. So I think what Gina has said is we have seen that, and that could be one of the reasons, is that somebody's looking and no one is able to mentor them through or support them in making that decision on a much regular basis. But you train them for 5 days, and you tell them to go and start screening on their own. And all of a sudden they can't remember, did you say that when, this is eligible for treatment, this is not, I have to look for a typical vessel, or I have, so such things. So there's a lot of close, regular monitoring that is needed for that sensitivity to really increase.
Okay, thank you so much, folks. The same person who asked the question did follow up and basically ask, should we forget VIA and go to HPV DNA screening? And I'll I think that what we've heard from Sharon and from Gina suggests that the world is moving toward HPV DNA screening. But a very important point, and I don't know if anyone else wants to expand on this, is that the HPV DNA screening does tell you if the woman is at high risk. It's a great screening method, but it doesn't give you any indication of whether it's precancer that's treatable with, say, cryotherapy or thermocoagulation, or if it's invasive cancer that the woman has. So everybody still needs a method of visualization of the cervix in order to select treatment modality. And of course, VIA can be, in spite of the challenges that we've heard spoken of, can be a great method for visualization and is necessary to move on to treatment. And of course, screening doesn't make any sense without treatment. I don't know if anyone else would like to comment on that.
Yes, Gina, I think I alluded to that when we talked about secondary prevention. It really is fundamental, and when we look at screening programs, we need to be ensuring that we're looking at the appropriate follow-up of screen-positive women. That really is one of the most important endpoints. It's really not helpful to screen women and have them receive a screen-positive result and not have a system where they are able to get the follow-up and perhaps treatment. Ophira mentioned that already. I think the last points on one of her slides was we really need to make sure in countries that are screening, we also then have trained gynecologists and trained surgeons who can do treatment, particularly for if you're at stage 1 of cervical cancer, where a hysterectomy is part of the treatment plan. So I think it is. I think that if countries can only get VIA going, they should get that going. But certainly most recommendations, and for instance, even the latest American Society for Clinical Oncology document, which does a really nice job of laying out recommendations based on the sort of income status of countries. And if you're a very low income country, VIA may be where you start, but certainly middle to high income countries, HPV is where you want to start, and even in low-income countries, you want to be moving towards, as they are in Zambia, moving towards HPV testing. But having that system in place where women who are positive can get treatment is critical. Otherwise, you're not really achieving your goals.
I think a quick addition is just to say one of the policy guidelines that was given by the cancer control team in Zambia is not to separate. And you see sometimes it happens where a woman is getting screened somewhere with VIA and then she has to move to another place to get cryotherapy. That, for a start, was something to just be able to do what Gina has said, is that every center that is opening must have the two together, so that the women who should on the first level receive either cryotherapy or thermocoagulation must receive it in that visit. And I cannot say better than she has said, if we do not follow up the women who are screen positive or even have cancer, then we shouldn't even start screening them. So ensuring that the system has the screening, we do the VIA and we treat immediately, or is the way to go, because that in the first instance will reduce on the loss of follow-up. Then ensuring that they've gone to the next stage if they have a more complex lesion is also important. And I cannot, to be able to say, no, let's do away with VIA because we have sensitivity issues, I would not advocate for that at all, because it's where you start. Where are you? Like I mentioned, what is your budget? How are you going to increase accessibility? We look at HPV DNA testing already. We are looking at saying, how are we going to make sure the woman that side has? It's probably going to be a two-way thing. In some settings, we're using HPV testing until the other areas are getting improved to a level where we find a way or have worked around that place to improve, to be able to, the health system to reach them. So no, I wouldn't advocate that if you don't have anything and you can't afford HPV testing, and say no, just go for HPV testing. Start where you are, because at least even then with sensitivity issues, you will be able to save women.
I just have one comment, if I may. It's Ophira. I totally agree with what has just been said. I would just add, from the WHO perspective is, and as well as the American Society of Clinical Oncology sort of resource stratified frameworks for cervical cancer control. first point is that it's not only about the income, but also actually about the resources. So you may have a lower middle income or an upper middle income country even where in some settings it's, there's enough infrastructure and there's enough financial contribution towards the whole package of interventions that you certainly can start with HPV. You could look at triaging to one of several methods, including VIA or not, if you have gynecologists available and colpo available, et cetera. And in other, more rural settings, et cetera, you may be looking at a different modality. The only other comment I'll make is that WHO and in the pink book, as they call it, you can look up online, which is the overall guidance for cervical cancer prevention and control. It's not perfect, of course, like any guideline. It needs to be updated and fairly frequently, given how fast this field is moving. There is a section where it sort of explains in a way of triaging what an approach might be to consider for a country. Screening and same visit treatment, exactly as Dr. Kapambwe just mentioned, is ideal, but certainly not achievable at every site. And one may think, well, if we don't have cryo available right on site in this clinic, should we even use VIA? I would just caution against a blanket statement to say you shouldn't start at all, because there are models for where, depending on the infrastructure and the transport system, et cetera, you can have an opportunity for women to return to that same clinic, and perhaps once a week there's somebody available for cryo, or perhaps there's a nearby facility. Now, of course, that raises the risk of being lost to follow-up. For sure, that's a big problem. But I would encourage us to think a little bit creatively here. While we talk about supportive supervision and mentorship to make sure that VIA is of the best quality for the reasons already described, that it's very operator dependent, absolutely. I would also encourage us to think about ways to navigate patients through the health system, and this can also serve to strengthen the health system in other regards. This is a way that you can improve the access for patients found to be positive, whether it's HPV or for VIA positivity, and to lower the chance of loss to follow up. Thanks.
Great, thank you. Thanks to all of you for a really, really interesting discussion. We're going to switch now to a question about HPV vaccine and vaccination strategy. Really interesting question that I actually haven't heard before. Oh, pardon me. One of our audience members said that some countries are considering vaccinating women who are HPV negative through DNA testing. So negative now, should they be vaccinated? Any comments? I guess we have to assume that those women are old enough to be screened.
Yeah, it's Gina. I'm happy to have my other colleagues jump in as well. I think that, yeah, there is actually a program, one of the ambitious programs proposed to really, in a rapid way, sort of eradicate cervical cancer is a rapid sort of vaccination of, women up to sort of 45, 50, as well as screening. So really just sort of blanket the entire population. For me, I think when I hear about these kind of programs, I think what I really go back to is some of the great work by Laura Bruni and colleagues who published recently, who are still showing that we are overall at less than sort of 3% for vaccination in the adolescent girls who would really benefit from it. So while a woman who's 38, who is HPV negative, would absolutely benefit from the HPV vaccine, and we have studies to show that, at a system level, when I think about a system level, that would not be my priority in terms of energy. Where I think we really need to keep our eye on the prize, the optimal place for the vaccine to work is in pre-adolescent girls who have yet been sexually active, and they will get the best benefit. So will that strategy, as part of a bigger sort of global strategy to eradicate cervical cancer, when we ultimately get there, is that a good idea? Absolutely. It would be it would be beneficial. But knowing, as I do, how there are limited resources at the government and policymaker and healthcare system level, I always, when I hear these type of questions, I always reiterate where our priorities need to be and what our numbers are at. And we really aren't even achieving the type of level of coverage we want in the pre-adolescent girls. So really, if there's energy, that's where I would advise and counsel that people start and really get those numbers up first.
Any other comments?
I was actually waiting. That's a debate that has been going on in our National Cancer Control Technical Working Group of thinking, yes, so if we start HPV testing and we find these women, of course we know that HPV testing that will have, 16, 18 is one of the oncogenic types that they'll be able to give us answers to. Why shouldn't we vaccinate them? I mean, if they are going to pay, as like Gina has said, the priority is for the adolescents, and I think that's where we need to put the energies. If they ask that I'm going to buy my own vaccine and I want to get vaccinated, that's a totally different issue. But I think on a public health scale, as evidence points to and as resources point to, it would be great that we really concentrate on the adolescent girls. But that's a discussion that has been going on in our country, on our technical working group as well.
Spoken like a manager of public sector funds. Great. Sorry, I interrupted you.
Sorry, Scott. I agree completely with that. And when I was at WHO, this was also a discussion, of course, regarding, I don't know if anybody's brought this up yet, but I don't see it in the questions, the vaccination of boys. So not to open up a can of worms at the moment, but just to say that the strategy by which governments are asked to make priority, decisions about their priorities from a public and population health standpoint are different than what we might suggest for, let's say, our own patient if we're a provider. So the discussion that you might have for those providers out there who might have women asking that question, it's important to be informed about this as you're doing, but to think that when it's up to the government to allocate resources where they're going to get the most bang for their buck, the greatest benefit for the largest population. In the case of women, it's not really clear in terms of the cost effectiveness, exactly as was said. And boys being vaccinated is an issue that's very important to consider. Governments are looking at this. WHO will at some point be looking at this because it's certainly here and available. There are models to try to estimate what percent coverage would you have to have for boys and girls. Could you have a lower coverage for girls if you have certain level of coverage for boys that could achieve the same herd immunity, which means immunity for the whole group, although every person in the group may not be vaccinated. So I would just suggest you stay tuned for more on these discussions.
Excellent. Thank you, everyone. We're almost at the end of our hour and a half, though we started a little late, but I'd like to end on time. Any other points that any of the presenters would like to bring up before we close? Okay, maybe one last and quick question, and maybe I'll ask you, Ophira, because you did refer in your presentation to getting technical assistance. Can you suggest to the audience places where they might go to find further information that would help with strategic planning or day-to-day management of programs, that kind of thing? Where could they get some good resources for that?
Thanks, Scott. That's a great question. I think it will depend on the country and on the setting, but I would suggest, if you're asking in terms of a country, we've got examples like Dr. Kapambwe's great example in Zambia that you could certainly reach out and see how they've been able to achieve their outcomes so well. But from the global perspective, you can contact your WHO country office, which often is very engaged with their ministries of health, of course contacting the ministry if you're not in the ministry, to look for guidance and see what the strategic priorities are. There's also something called the, it's a portal that the National Cancer Institute in the U.S. hosts on national cancer control planning. For some reason, the name of it suddenly escapes me. Anyone else on the call?
African Leadership Forum.
Oh, there's the African Leadership Forum, of course, but I'm also referring to a portal that is publicly accessible.
Oh, okay.
You can Google National Cancer Control Plan portal, NCI, the National Cancer Institute, which happens to be the U.S. NCI, that houses, you can even download the actual National Cancer Control Plan for different countries. So if you're not aware of what your own country is doing, you can look and see if it's there. You can also read through other documents to get guidance on how they were able to prioritize their strategies for cervical and other cancers. But we do recommend, WHO and the UN agencies and the joint program really promote the idea that cervical cancer control should be a key priority for all countries, and there should be some specific guidance within the National Cancer Control Plan on the cervical cancer control plan within it. And that has to include, timelines, metrics, and an action for prioritizing where funds are going to come from. And of course, nothing happens in a Ministry of Health alone. The Ministry of Finance ultimately must be involved. So looking to see if there's a budget line item in your next, overall budget that includes something in cervical cancer. Those are kind of broad statements, but I hope that's helpful as a starting point. You can contact me if you like as well.
Scott.
Yes. Please.
And I think, one other thing that if you look at the countries around, I see that there, as different countries, we probably get different strengths in terms of how we've done our work. If I, for example, we're looking at including indicators into the government system, you find that Botswana has already started doing that. So it would be imperative, I don't know who can gather that information to know which country has done something that they've done, putting indicators into their government system. They have now moved towards HPV testing, and they have a VIA platform. So a country like Zambia that is going to look into, HPV testing and have VIA as the next line, can exchange with Botswana. You look at Malawi with telepathology, and they've been doing it for some time with UNC, and vaccination with Uganda. So there are these, I think, country strengths. You come to Zambia, is how are we managing to blow this program to ensure that it has taken, there's a lot of political will, it's recognized in the ministry, they know this exists, and they actually now have a national cancer control unit that they want to, organize, ensure that the strategic plan is, there's somebody monitoring and trying to see that we're moving the way we should. So in between countries have done great things in their own strides, Uganda having the Cancer Institute and how they organize in their structures. So we can be able, there are synergies that we can look within, even within, like, for example, for Africa that I can talk about, and be able to contact those, like Ophira says, maybe start from WHO and they can go into government and we can get that expertise and get help and try to see how we can move on.
Thank you.
Excellent.
I've also just posted in the chat window to everyone the ICCP is what I was referring to. That's the International Cancer Control Partnership portal that actually has a link to national plans that you can look at and download. And also the UICC, the Union for International Cancer Control, can sometimes be very helpful for guidance going forward.
And one other source, and I've put the URL up there in the chat window also, is the row.org cervical cancer library that includes the pink book that Ophira mentioned before, the WHO publication. Row pulls together things from all sorts of sources around the world and brings them to you. So we're at the end of our hour now, and I want to thank my three panelists who did just an excellent job today. Also want to thank all of you who joined the call, and to ask everybody for forgiveness for the technical glitches that we had at the beginning, but I'm certainly glad that they didn't continue to plague us throughout the meeting. Thank you, everyone, and you can look for the email that will show where this webinar was archived online. I'll put that up in a couple of weeks, and if you have colleagues who you think would be interested, please share that with them. Thanks again, all.
Thanks.
Okay, bye-bye.